Fibroids can be found in up to 70% of women by the age of 50. But most never cause symptoms or need treatment. So when do they matter? Let's talk about it. Ooh, sit. Stay. Hello and welcome back to Ikunna, MD. This is my YouTube channel where I talk about all things related to medicine, mindfulness, and self-care as a Black woman. And I'm very excited about this video because it's a topic that's near and dear to my heart. It's related to my work. I am an OBGYN resident living in Vancouver, but also fibroids are something that are, I think, 3 times more common in Black women, and yet a lot of my friends and family, when I talk about fibroids, have really no idea what I'm talking about. And so I wanted to make this video just talking all about something that I think is important for people to have some knowledge base on. I want this video to feel casual, but also highly educational. And I'm going to be explaining things pretty in depth, but trying to break them down in a way that's helpful for anyone, from a medical learner, like a medical student, all the way to a friend, family member, because I think that the way I explain things to a patient, I try to explain very similar to how I explain to a medical learner, because I think that anyone can understand these concepts if we break them down appropriately. Of course, this video is not a substitute for medical advice. If you are concerned you have fibroids or you're concerned about anything to do with your health, please seek help from a medical professional in person. I am really grateful for all the residents and physicians in the past that have made videos and podcasts about these topics, and I just want to contribute to the body of work that we have online to learn. So first, let's just break down a myth that I think is really common, which is that if you have a fibroid, you require surgery, which is definitely not the case. In medicine, we care a lot about function, and with fibroids, as they are benign, aka non-cancerous growths or tumors, not all tumors are cancer. Fibroids can also be called leiomyomas. We often don't need to treat them unless they're causing problems. We don't just rush into surgery, which has its own risks and complications for anybody. But they do matter because fibroids can cause people to have bleeding, they can affect your fertility or ability to conceive in certain situations, etc. So first, the basics. What is a fibroid? So a fibroid is a benign growth of the muscular layer of the uterus, or the myometrium. So the uterus has 3 main layers. There's the endometrium, the lining of the uterus, and that's what grows and sheds with your period every month. Then there's the myometrium, which is the muscular layer around the uterus that allows the uterus to contract, like particularly during the labor process when someone's having a baby. And then there's the outer layer, the serosa, kind of like a shell, or almost like, almost like a shell or a jacket or something like that around the uterus. That's connective tissue that just provides structural integrity to the uterus. So when we talk about a muscular layer like the myometrium, which is where fibroids originate from, we're talking about smooth muscle. So there's 2 types of muscle in your body. There's skeletal muscle, which is kind of like, it's basically the muscles that you think of when you're exercising, muscles in your arm, your legs, things like that. They're voluntarily controlled muscles, whereas smooth muscle in your body are involuntary muscles that contract in your body as well. So a fibroid is considered a benign tumor. And like I said, not all tumors are cancerous. I know there is a type of uterine cancer called a leiomyosarcoma. So now, prevalence. How common are fibroids? Like I said in my intro, fibroids are actually quite common. If we did an ultrasound of all women from throughout adulthood to age 50, 70% of women would have fibroids seen on that ultrasound scan. With that being said, many of them are likely very, very small or not causing any issues or any problems that they would have even noticed in their life. These are commonly found incidentally, and that means when you're having an ultrasound scan for something else, like you go to the emergency department because you're having abdominal pain and you have an ultrasound scan to assess for what's causing it, they might find out you have an appendicitis, but they also might see, hey, this person has a few fibroids. And in that case, the person may or may not have any symptoms of having fibroids. Now, fibroids are more commonly seen in Black women, and so we often see Black race listed as a risk factor for fibroids, and I have a lot of thoughts and feelings about race as a risk factor, listed as a risk factor for things. I I think, of course, it makes sense for us to be aware that Black women are definitely more prone to seeing this. But I think we have to ask ourselves why that is. And, beyond genetics, I've spoken in a previous video about hair, how we do see an association between chemical hair treatments, relaxers that are commonly or have been commonly used in the Black population. We do see an association between those and fibroids. But I don't think we actually have a good understanding of a causation mechanism. I do think that these chemical treatments can act as like an endocrine disruptor is the theory so far. But with that being said, the reason why I do struggle sometimes with having race listed as risk factors, because I think that when we see patients and we see them presenting with something that could be concerning for a fibroid or could be cause for fibroids, I think it's very easy to get tunnel visioned and focus on what is the most common likely diagnosis, which for Black women often is fibroids, but potentially miss other things if we aren't keeping our differential broad. And so no matter what, even though things can be more common in certain groups, such as fibroids in Black women, and I do want Black women to be aware of that, I also want people to remember that there are other concerning causes of bleeding or pelvic pain that could be caused by something else that's not fibroids. My dog. That could be caused by something else that's not fibroids, and to not let ourselves get too tunnel vision because something is more common in a certain racial group. Other risk factors for fibroids, I will list them here, but age and increasing age we know is a risk factor. So when people get older, we tend to expect to potentially see fibroids more often. And then also sustained estrogen exposure is thought to also be associated with fibroids. We do know that estrogen can be produced in fat cells. And so with obesity, we tend to see more estrogen exposure, as well as people who start their period early, their body has more time in terms of exposure to estrogen. The pathophysiology of fibroids, why do they happen? What causes them to grow? We know it's to do with both estrogen and progesterone, which work synergistically or work together. So what we find with people with fibroids is that their tissues overexpress receptors for both estrogen and progesterone. Estrogen kind of works indirectly because it basically primes the tissues and causes more progesterone receptors to be present. But the progesterone itself is really what drives the growth of fibroids and acts on those overexpressed receptors to cause, abnormal growth. Another important aspect of fibroids is how we classify them, and we have a classification called the FIGO classification system. And I'll put an image on the screen here, but basically we have different categories of fibroids. First, we have submucosal fibroids, and submucosal fibroids are the ones that really interact the most with the endometrium, and they push into the cavity of the uterus, and they tend to cause bleeding symptoms because of that. The endometrial lining, like we talked about before, that's what grows and sheds with your period, and so something that's distorting that or affecting that is really going to disrupt people's bleeding patterns. We also have intramural fibroids, so those are the ones that are just within the muscle layer wall of the uterus, and some of the lower category ones will have some interaction with the endometrium or just abut it or just distort the cavity enough that they can impact bleeding. And then as we get more on the outside of the uterus, we call those subserosal fibroids. Those tend to cause more bulk pressure symptoms, constipation, urinary symptoms, because they're some of them pushing on someone's bladder, depending on the location of them, less bleeding symptoms with those ones. And that leads really well into the clinical aspect of this. What are the actual symptoms someone has with fibroids? And like I already mentioned, the most common symptoms tend to be bleeding for people who have fibroids that are distorting their endometrial cavity or interacting with the endometrial lining, especially if they're large, and bulk and pressure symptoms like we talked about. Pain we do see occasionally, particularly if a fibroid starts to outgrow its blood supply and degenerate. We call that a degenerating fibroid, and those can be quite uncomfortable. Sometimes people will present with fertility issues. So how do we diagnose fibroids? And typically what we do is we see a person, they typically will have symptoms, and they'll have an ultrasound scan. Ultrasound is our go-to for assessing for fibroids. We can use MRI as well, but in Canada, we don't use MRI, willy-nilly. We typically use it for more complex cases or surgical planning. If someone has significant bleeding symptoms, we tend to do an endometrial biopsy to make sure that we're not missing a precancer or a cancer inside the uterus. And this is what I mean about not getting tunnel visioned and making sure you are kind of checking for all kinds of diagnoses, no matter the patient in front of you and what their risk factors for fibroids may be or how obvious it may seem, because more than one thing can be happening at once. The history, asking questions about what they're experiencing, and the physical exam to see what the fibroids feel like, where they are, see how significant someone's bleeding is, if they're coming in with more acute heavy bleeding, things like that. And also if they are going for surgery, surgical planning, it's really helpful to do a physical exam just to see what kind of we can expect with the surgery and how complicated it may be, or if they need to see someone who's more of a minimally invasive fibroid specialist to have their uterus removed or have their fibroids removed. As part of fertility workup, they will do testing like HSG testing or HyCoSy. Those tests can help to assess her pathology inside the uterus. We try to assess that the tubes are open as well. If we're really not sure, and even ultrasound sometimes, ultrasound is not 100% perfect. If we're really not sure and someone has abnormal bleeding, we also can book a diagnostic hysteroscopy, which is a camera surgery where we look inside of the uterus, and sometimes we find fibroids during that time that weren't necessarily obvious on ultrasound. What are the treatment options for fibroids? And this is where there's a lot of different things to go through. First option is doing nothing, expectant management, watching and waiting. And this is something that we're going to recommend for anyone who has fibroids that do not look concerning, for like a leiomyosarcoma, and have no symptoms, and these were just found incidentally. They're not bothering you, you don't need to do anything about them. Or for people who, they might have some bleeding, they might have some pressure symptoms, but it's nothing that's super bothersome to them, nothing that they really notice in their day-to-day life, and they don't really want to pursue treatment for that. Then we go into medical management, which is our conservative category of options. So we have non-hormonal medical management and we do have hormonal medical management. In terms of non-hormonal medical management, really we're talking about managing bleeding for the most part. So when it comes to managing bleeding, one of our first options is tranexamic acid, and we often will use this for people just to help with their symptoms while they await other treatment. And so it's an anti-fibrinolytic medication. A fibrin or fibrinolysis is part of our coagulation cascade, and fibrin is what helps your body to form a clot. And so if we use an anti-fibrinolytic, fibrinolysis is the breakdown of fibrin, we're trying to prevent the breakdown of fibrin to help your body clot off bleeding and to help make your bleeding lighter. And often this is something we'll use for anyone who presents with heavy bleeding, heavy periods. It's a nice non-hormonal option for people. So another non-hormonal option are NSAIDs, or non-steroidal anti-inflammatory drugs. And these are medications like ibuprofen or naproxen. And these can be helpful to reduce bleeding, especially if they're taken 24 to 48 hours before you expect your period to start. And then we have several hormonal options. And so, of course, hormonal medication or contraception can be very controversial on the internet. And so I want to emphasize that these medications are used to help people's quality of life, to help their function. Of course, there are people who do not tolerate hormonal medication very well, don't like how they feel on it, can cause mood side effects or other side effects, breast tenderness. But for a lot of people, they help people be able to live their life and live their life that is of high quality to them. And that's particularly true for people with endometriosis as well. And also they are very effective at preventing pregnancy, and pregnancy itself has many risk factors. And in fact, a lot of the risks that we see of the birth control pill or in contraception or hormonal medication are much, much higher in pregnancy, just to put that out there. And so in terms of hormonal options, we have combined hormonal contraception options that we can use to help manage bleeding. So those like the birth control pill that has estrogen and progesterone in it. We have patches and rings. We also have progesterone only options that are good for people who do not tolerate the estrogen component of combined hormonal contraception well, or people who have contraindications to estrogen, like people who have blood clotting conditions, people who have a history of estrogen-dependent breast cancers, things like that. We have a progesterone only options, progesterone only pills, as well as the DMPA injection. I don't see that used as commonly, at least where I work, but it is an option. IUDs can be used, but often cannot be the best option when you have, significant fibroids that are within the endometrial cavity, because there's a higher risk of the IUD being expelled during a heavy bleed. And so how do these medications work, and why do we use them? So for one, when we use combined hormonal contraception, so the estrogen component of a birth control pill is kind of like, we say it's like a fertilizer, and progesterone's like a lawnmower. And so the estrogen component of the medication stabilizes the lining of the uterus, so it's kind of in a steady state, and the progesterone kind of counteracts the estrogen, so there isn't just unopposed fertilization or unopposed growth of the lining. So it kind of keeps things even keel, so there isn't this kind of growth and heavy bleed, growth and heavy shed. The way that the birth control pill prevents pregnancy is by preventing ovulation. In terms of our progesterone-only options, similarly to how they act in the birth control pill, progesterone leads to endometrial atrophy, so basically like a decrease in the thickness of that endometrial lining, because it's like that lawnmower effect, and decidualization. So decidualization is a process that the cells in the uterus go through before, when they're preparing the uterus for pregnancy. So your body does not know if it's going to be pregnant or not until there's actually a fertilized egg that implants into the uterus. So every month during your cycle, progesterone's acting in your body naturally, preparing the uterus for pregnancy. When we use progesterone in a medication, we're getting that similar effect, but we're using it to our advantage, because a thin endometrial lining and a lining that's gone under decidualization, now that lining has cells that are more structurally stable. The vascularity is also more stable. The progesterone also has anti-inflammatory effects that help to reduce the amount of bleeding people have. And so progesterone-only options are really great in terms of stabilizing the lining and preventing significant bleeding. In terms of other medications, we do also use GnRH agonists or Lupron, which is a medication that helps to decrease the size of fibroids. These are for a preoperative treatment. If we're going to be treating large fibroids, we like to try and get them to obviously as surgically optimal, as small, and as less vascular as possible. And we know that a GnRH agonist like Lupron can decrease the size of fibroids by up to 50% in 3 months. Or it can be used as a bridge to menopause if someone's very close to menopause and it's causing them symptoms and they don't want to have surgery, because we do know that fibroids tend to regress, decrease in size after menopause. With some occasional exceptions, we see people after menopause with fibroids. The thing to be aware of with Lupron is that we are basically inducing a state of menopause for the patient. And so we don't want someone to be on Lupron long term, at the very least, without add back therapy to support your bone, heart, and brain health, because we know that the circulating estrogen in particular that people have before menopause is really important for their health. Overall, medication is about controlling symptoms. It's not about getting rid of the fibroids. The definitive treatment for fibroids is surgery, and that would be with hysterectomy. That's the only way that we can for sure take care of fibroids. The other surgical option that we do see used is a myomectomy. So a myomectomy is just removal of the fibroids and leaving the uterus in place. And we only like to offer that for people who would like to have children in the future and thus need their uterus. For people who have completed childbearing and have significant fibroids that are bothersome to them, we do recommend definitive treatment with surgery in that case, particularly if they have failed medical management, or if the fibroids are just really large and they're significantly symptomatic, they're having heavy bleeding that's causing anemia, etc. So in terms of myomectomy, it's important to be aware that myomectomy is actually a higher risk surgery than hysterectomy. There is quite a significant bleeding risk with that surgery, and also the anatomy can be quite distorted, and obviously there's risk with any surgery. And also, if someone were to get pregnant after having a myomectomy, there's now a scar on that uterus. And so there can be increased risk of uterine rupture in labor. So just something to be aware of when anyone's having a pregnancy with a uterus that has a previous scar from either a C-section or a myomectomy. We are very mindful and monitor them closely when they present to hospital at labor and delivery. They also can be at risk of abnormal placentation. So the placenta encroaching into the wall of the uterus. So we call that placenta accreta, increta, or percreta. And they also can be at risk of preterm birth. When we do manage these surgically, we often will use surgical adjuncts to help reduce bleeding during surgery. So we'll give them tranexamic acid, which I talked about before, vasopressin, which is a medication that helps to reduce bleeding by contracting the blood vessels that go to the fibroids, or epinephrine, etc. There are other options we can offer for uterine-sparing surgery for people that really, want to keep their uterus. And those are things like uterine artery embolization. So embolizing the arteries that that supply blood to the uterus to help basically degenerate the fibroid. And this is a good option. However, it can be quite painful following the procedure because the fibroid is literally being cut off from its blood supply. And it can take time to have relief. It can take up to 6 months to really see significant relief from that. And we do see, I think, about 30% of people who have embolization will end up, needing further treatment, likely with a hysterectomy for definitive management. And we have other options that are uterine sparing and more up and coming options as well. Radiofrequency ablation, high intensity focused ultrasound, etc., that I won't go into, but I will put more information in the description box, especially over time. If we see developments and changes, or if there are things that I felt like I was missing, I will add them to the description box down below. So overall, the treatment's based on patients' symptoms, their goals in terms of treatment, in terms of do they want to go on to have children? Are they done childbearing? And just a discussion between the patient and the healthcare provider about what makes sense for them. So I finally want to do a section about the challenges of fibroids. We're talking about complications. So I've already mentioned a few of these. One is degeneration, which can cause acute or, more sudden pain that's quite significant when that fibroid outgrows its blood supply. So fibroids are quite vascular, but if they're growing to be quite large, for some patients, the fibroid will outgrow its blood supply and then start to necrose or die off, and that can be really painful. And so if you do have fibroids, or someone does have fibroids, we often will tell them if they are having, severe pain when they're waiting for treatment to come to the hospital if they're having significant pain. And in terms of treatment of someone with a degenerating fibroid, it's typically just about pain control. Typically, we admit them and just treat their pain. And we give them NSAIDs to help with reducing inflammation. If we're concerned about infection, then we typically will add on antibiotics, but typically people will improve within a couple of days. Sometimes people will have a large fibroid that's coming from the uterine cavity or the cervix that's kind of prolapsing outside of the cervix and into the vagina, and those can cause quite significant bleeding and typically require more urgent removal. I briefly mentioned leiomyosarcoma, which is a form of uterine cancer, and our knowledge of these typically so far seems to be that they arise kind of on their own or de novo. Less than 5% arise from malignant transformation of a fibroid, but it is something on our mind. It can be very hard to differentiate these when they're just an early stage of cancer versus a fibroid tumor. If we do see any concerning features for leiomyosarcoma, or if we see someone with a rapidly growing fibroid after menopause, these are things that make us think maybe we should send them to the gynecologic oncologist for evaluation before we do a surgery. There's no diagnostic test that's been found to definitively know for sure whether something's a leiomyosarcoma or a fibroid preoperatively. Fertility is often a scary topic, and I want to be very mindful talking about fertility and fibroids because, like I said, fibroids can be very, very common, and so I don't want someone to think that if they're experiencing infertility that it must be related to their fibroids. Our understanding of infertility and fibroids is that often with people who have otherwise unexplained infertility, if there's a structural fibroid inside the uterine cavity, we definitely have strong recommendations for removal of those submucosal Vigo type 0, 1, 2 fibroids that can distort the endometrial cavity. We have much less understanding in terms of fibroids that are intramural. If they're distorting the cavity, there is some discussion around removing those, but we don't have as strong of an understanding of those fibroids as we do the submucosal ones, at least to my knowledge. And then pregnancy, people who are pregnant and have fibroids. So we do know that, having something that's in your uterus that's affecting the cavity can increase your risks in pregnancy. And we also can see fibroid degeneration in pregnancy as the uterus grows, and again, affecting the vascularity of the blood supply to the fibroids. And so we do sometimes have to admit people during pregnancy to help manage fibroid degeneration. Malpresentation, so with something that's obstructing the uterine cavity, it can affect your baby's ability to get into the optimal position for labor. Just because you have a fibroid during pregnancy does not mean you'll require a C-section. We do have good data that shows still quite high vaginal delivery rates for people who have fibroids. Higher rates of postpartum hemorrhage, because after someone has a baby, the uterus needs to contract down, or else they will just really continue to bleed, because the uterus contracting down is really what helps to close off those blood vessels and prevent significant bleeding. And so if you have an anatomic distortion of the uterus, it can impact the uterus's ability to contract during the immediate postpartum period. And so if you do have fibroids or significant size fibroids, your pregnancy likely will need to be managed by an OBGYN, or at least co-followed with an OBGYN. So to wrap things up, I just want to highlight some key points so that things that I want to make sure you take away from this video. So first, fibroids, leiomyomas, they are benign growths of the muscular layer, the myometrium of the uterus. Majority of women by the age of 50 have fibroids, but only a small proportion will actually have symptoms. Treatment is based on a variety of factors, particularly symptoms like heavy bleeding, bulk symptoms, and the goals of treatment. So in the description box, I will have my references. We'll also have surgical videos linked down below for anyone who's interested. Thank you so much for watching this video. If you stuck around to the end, please subscribe if you enjoyed it, and let me know if you have any other topic areas that you'd be interested in, because this one is just one that I felt that feels really near and dear to me. All right. Thank you so much for watching. Have a great rest of your day, and I'll see you in the next one. Bye.